Hello everyone, welcome back to my channel. So today we are going to discuss about the esophagus motility disorders. And some of the disorders of motility includes achalasia, cardia, diffuse esophageal spasm, nutcracker esophagus, when the peristalsis is so strong that when it relaxes or when it contracts, it closes as crackling sound. Next is pharyngeal pouch and secondary causes. So first we are going to discuss about achalasia cardia. Achalasia cardia, in which the esophagus or lower esophageal sphincter is not able to relax. Normally, when we take food, it will convert into bolus, then the peristalsis where it takes place, and the meningeal plexus inhibitory neuron stimulated, which relaxes smooth muscles, and the food passage takes place. But in the case of achalasia cardia, lower esophageal stone remains increased, and it fails to relaxation, and the food cannot pass. So, peristalsis takes place in the two-thirds of the esophagus. Next is pathogenesis. We already discussed it remains contracted, meningeal plexus stimulated, inhibitory neurons stimulate, nitric oxide releases, and dilation takes place. But in case of achalasia cardia, this meningeal plexus reflex loss takes place. So in achalasia cardia, what are the causes? The first cause is idiopathic. We do not know what are the causes. Second can be Chagas disease, in which aganglioma takes place, absence of ganglion. Third is diabetic neuropathy, and fourth is amyloidosis, sarcoidosis, or we can say next is pseudoachalasia. What are the clinical features of achalasia cardia? When the food cannot pass from the esophagus to the stomach, so dysphagia will take place, and it will start from the gradual onset, then intermittent, and then persistent, which will increase on standing or moving. So dysphagia is for both solid and liquid in the age group of less than 50 years. When the food cannot pass to the stomach, it will not digest, it will not circulate in the body, so weight loss will take place. Nocturnal cough, regurgitation, or when it moves to the lungs, aspiration will take place. So how we can diagnose this achalasia cardia? So first is endoscopy, which is all for esophagus disorders. Second is barium swallow. We can see both beak appearance. From above, it is dilated, and from below, it is beak-like appearance. We can diagnose from manometry, which is very important, and it will measure the pressure, and the lower esophageal sphincter pressure is increased in this case. How we can treat achalasia cardia? First is pharmacological. We have to relax the muscles, so we'll choose calcium channels blockers like amlodipine, nifedipine. We can choose nitrates. We will choose botulinum toxin, which will inhibit the release of acetylcholine and which will relax the muscles and will allow the food to passage. Next is non-pharmacological. Non-pharmacological, we will provide endoscopic balloon dilation in which the esophagus will dilate. And if pharmacological and non-pharmacological is not effective, we will provide surgery, which is Heller's myotomy, in which we will cut the muscle. Or we can do fundoplication. And later on, we will provide PPIs. So what can be the complication of this achalasia cardia? Esophagus line is squamous cell, so we can say squamous cell carcinoma. Candida esophagitis, diverticulitis, aspiration pneumonia when it moves to lungs, or obstruction. So these all about achalasia cardia. Thank you so much. That's it for the video, and please subscribe to my channel for more videos.